I bring to you greetings from India. I'm extremely delighted and happy to share my thoughts to the Society for the Advancements of Geriatric Anesthesia. I'm Dr. J. Balavenkatsubramanian, Senior Consultant Anesthesiologist at a 650-bedded tertiary care referral center, the Ganga Medical Center and Hospital, Coimbatore, India. This is the hospital where I work in. We have 38 operating rooms and we do close to 125 surgeries per day. And my interest in geriatric anesthesia started way back in 2002 when anesthesiologists took over as perioperative physicians. And by the virtue of having patients over the age of 65, especially coming for hip fractures, joint replacement surgeries, and also deformity corrections in the spine, geriatric trauma, apart from hip fractures, my interest in geriatric anesthesia became profound. And I'm happy to share that the knowledge that we gained over the last 2 decades is based upon what we do when the patient arrives into the hospital. So the anesthesiologist took over the entire management of the perioperative care, including preoperative assessment and rehabilitation, intraoperative care, which is designed and tailor-made based on the requirements of the patients with the associated comorbidities, and tailor-making an anesthetic plan for them to produce least disturbance to the internal milieu, and looking after them in the intensive care unit and the high dependency unit in the postoperative period. And also the anesthesiologists are posted in the ward. So the geriatric patients are looked after by the anesthesiologist in the ward also. This gave us several insights into the common problems in the post-surgical geriatric population, and we learned a lot. And the more we challenged, the better we became. And today I'm going to share some of the thoughts which I've learned from here and the general scenario of geriatric care and anesthesia in this country. At this point of time, we have 84 anesthesiologists in our department. And in the night, we have 14 of them who look after the patient and offer the similar care to the patient right as if it's in the daytime. The common challenges that India faces today is it has got 138 million patients over the age of 65, and this forms formidable percentage of the population of close to 12 to 15% of the population in India, or those aged over the 65 years of age. We all know that when a newborn, it is so difficult to distinguish and identify between two newborns because they look extremely similar and identical. But as they grow, they evolve into completely two different individuals. And possibly we know this is because of the genetic preponderance, environmental influences, occupational hazards, general lifestyle. They completely evolve. So each geriatric patient poses a different challenge to the anesthesiologist based on these factors. In India, there are two organizations. One is the Indian Academy of Geriatrics, which the last 20 years has started doing significant work for the advancement of geriatric patients in this country. And there is yet another non-profit, non-government organization, HelpAge India, which works on making geriatric patients' life better. And the government of India also became clearly very keen in helping the geriatric patients. And they started a helpline called Elder Line. And if you call 14567, there is someone who will come for rescue of a geriatric patient. The Indian Academy of Geriatrics is clear in its vision and mission. So it says that geriatrics is a team-based, person-centered care, which clearly have the principles of robust clinical practice. The challenge is unique in that the aim varies in each patient. This might involve uncovering an atypical presentation of a medical illness, pruning medications that are unnecessary, identifying social and psychological barriers. At other times, principles of palliative medicine may have to be adopted. In all these instances, the priority of the geriatric team is on ensuring that older people enjoy the best quality of life, is what the Indian Academy of Geriatric works for. But there are several challenges in India because of the significant differences in the cultural, linguistic, and socio-economic diversities. It's a huge country. So these differences are very preponderant and very obvious when you travel across the country. There are also tremendous variations in disease epidemiology across the country, whether it's infection or non-communicable diseases. Addressing the challenges of rural healthcare access, navigating varied healthcare seeking behaviors, and rectifying disparities in healthcare delivery demands an understanding unique to India's context. By collecting geriatric data that is distinctively Indian, a spotlight can be cast on all aspects such as ideal management plans for native diseases, multi-generational living arrangements, caregiving dynamics, and social support systems. This is broadly to show the challenges that are unique in this country. And we also understand that in India, the physiological and the chronological age, there is a huge gap. For example, the one patient on the left is about 96-year-old when he came to us for a hip fracture surgery, but he was absolutely well nourished, well built, was communicable, his mental faculties were perfect, whereas the one you see on the right side was just 67 years old, but emaciated, hard of hearing, could not see properly, could not communicate well. So this disparity we see quite profoundly in our surgical patients. And one of the things which I really wanted to share here is we evolved in geriatric orthopedic care for hip fracture surgeries specifically over the last 2 decades. And we have got a clear path for these patients right from arrival to discharge, and it has made a huge difference in the outcome. On an average, we do close to 2,400 hip surgeries every year. And the minute they come into the hospital, the first person to see after the orthopedic surgeon who detected the fracture is an anesthesiologist, round the clock, all the days. So the first thing we do is, after reviewing the clinical parameters, biochemical parameters, written informed consent, we go ahead and do what is called as on-arrival block for this patient, 24 hours. So we found out that suprainguinal fascia iliaca block or a PENG block or a femoral block or the 3 ultrasound-guided blocks that are offered to this patient on arrival, and they are made pain-free immediately. We have also devised a strategy to see that we make sure that the internal milieu is corrected in the first 4 to 6 hours, and their comorbidities are assessed, analyzed, and the intensity of organ damage also is reviewed. And with all this, we tailor-make an anesthetic plan, and our best interest is to operate these patients within 12 to 24 hours. And we are extremely happy and delighted that clear clinical pathway with a lot of focus on early surgery, appropriate pain relief, correcting the internal milieu have all made sure that we offer the best outcome in our geriatric population. This is an excellent model which I wanted to present to you. So this was a case which I just did a week back, a 111-year-old geriatric person coming in for a hip surgery, and he was discharged on the 4th day because of the clear-cut clinical pathway and the postoperative care that we offer to this patient. And we have a clear, distinct plan of intraoperative care. Apart from the prehabilitation and acute preoperative correction of internal milieu, we have a clear anesthetic plan. We always go in for a combined spinal epidural in these patients, go with low dose spinal, and make sure that we maintain the mean arterial pressure in the perioperative period. When we go for a low dose spinal, it becomes prudent that the two segment regression happens faster. So by the 45th minute, we start giving epidural top-ups to maintain the same quality of surgical anesthesia and analgesia up to the T10 thoracic vertebral level. So maintaining these pressures throughout the period and making sure that you adequately replenish the fluids and blood. And also to maintain the normal temperature, DVT prophylaxis by both chemoprophylaxis and mechanoprophylaxis that are started immediately after the surgery. We have found that the intraoperative care is highly standardized, and because we maintain the pressures intraoperatively, we have found out organ perfusion is maintained in the challenging situations, especially intraoperatively, and postoperatively, we have found out least complication when you standardize your anesthetic plan and intraoperative care and close monitoring. And in the postoperative period, also I would wanted to emphasize all those issues which are associated with possible complications. Number one is pain. We make sure the VAS score is less than 3 for the first 72 hours by the multimodal analgesia. Make sure the hemoglobin level is kept at about 10 grams or a hematocrit of 30 grams %, especially when they have a cardiorespiratory compromise, or a hemoglobin of 9 grams % if they don't have a cardiorespiratory compromise. We make sure they move the bowels very well. Constipation is one of the significant problems. So we start medications right from the word go and make sure that they move the bowels. We also look after the bladder and make sure they are bladder catheterized if they're not able to void. The other issues we have found is hyponatremia and cognitive dysfunction. And these two things are usually looked for. And one of the issues we have is alcoholism. The minute we know the patient is alcoholic, we start with thiamine supplements, we go up to 1 gram. And measures like this have helped us to devise a strategy and a plan and a pathway to enhance the good outcome and to decrease the morbidity of this patient. So anesthesiologist working as a perioperative physician on a geriatric population with one leadership, with one aim, with one goal, with one point of contact, I personally feel our outcomes has been better. So this is something I wanted to submit to you as a beginning of my experience in dealing with geriatric hip fractures. In India, the geriatric healthcare, where do these patients go? The government-run hospitals are there almost throughout the country, and there is a primary health center for every small village in this country. This becomes the primary contact for many of these patients, especially in remote location. In slightly bigger cities, we have quasi-government hospitals, which is a combination of the local corporation along with the government. Both of them offer free treatment to our patients. But the now question is, are all the disease and surgical problems can be addressed in these two institutions? The answer is no. They have to be referred to a government medical college hospital, which is a tertiary care referral center, which can offer free treatment to these patients. So this is a structured thing that we see in the government sector. But considering the fact that a large majority of the Indians do not have an insurance system, the government medical institutions become the point of care for several of these patients. However, there are a large percentage of Indians who can afford their treatment. It is estimated 300 million Indians can offer any kind of treatment and they can pay for their own surgical requirements. So because of this, the private medical college hospitals grew up in this country, which also impart education and also treat the patient. Fortunately, this has become a big provider for many geriatric patients across this country. Then we move on to the next sector, the private corporate hospitals, and these are extremely well equipped. It could possibly be similar to any hospital in a developed country, offering all the services right from emergency services to intensive care unit to absolutely great infrastructure in terms of technology, in terms of human resources, in terms of offering the surgical expertise for even surgeries like organ transplantation. So this have become one of the hallmark of Indian medical care. And the last 2 decades has seen a tremendous progress in this private corporate hospitals offering services to geriatric population. And also, there are many small-sized 50 to 100 bedded hospitals in smaller cities, rural areas, and tribal areas run by private individuals who also offer services to the geriatric patient. There are also multiple charity hospitals run by non-governmental organizations and religious institutions which offer free services to the patients in various parts of India. So in general, the last decade has seen much more investment into medical care, and many of the geriatric patients are given the appropriate treatment. But there are certain obstacles. The obstacles are in the activity of daily living. In India, majority of the geriatric population slow down as they get aged. Their activity becomes very less. Majority of them can get confined to indoors and they don't get exposed themselves to sunlight. And because of this, there is an increased number of geriatric population who have severe sarcopenia and a very decreased muscle mass, and also quite a significant osteoporosis. So this is something which I think I wanted to emphasize. And also, preventive health is not prevalent in this country. Only when the disease comes, they get treated. But multiple measures for preventive health is just made a beginning, and it's not prevalent across this country. I wish that this becomes a norm. The other issue in our country is there is a lot of belief in alternate medicine. We have the Ayurveda, the Siddha, the homeopathy, and the naturopathy. These are alternate form of medical systems that are available in the country. And many of them believe in this. And I'm not too sure whether they offer similar kind of a solace to a patient like the established evidence-based medicine. And in some places, when they become older, they don't want to go and seek medical assistance, and they would like to go for native treatment, and they delay until last. So this is another challenge. But one of the advantages which I see in India is the family support system. Many of them live with their children, and this is an advantage in that certain disorders are identified early, and the younger people support the older population. So this is something which I wanted to share. The joint family system is still existent in many parts of this country. The common surgical requirements in India for which a geriatric patient comes to a hospital includes malignancy, osteoporosis and hip fracture, degenerative disease, they come for joint replacements, and cataract surgeries. And because of the prevalence of diabetes, it is established 30% of adult Indian population are diabetic, and we run a diabetic clinic in our hospital. So diabetic foot, especially with multiple comorbidities, autonomic neuropathy, coming with diabetic foot with infection is extremely common. And I think a lot of research is going on, and a lot of research has to be done in this. And this is where possibly we can collaborate. One is osteoporosis, second is dementia and the cognitive dysfunction, and third is the diabetic foot, which opens up the channels for Indians to work with your esteemed institution. In terms of comorbidities, the geriatric patient, the main issues are diabetes, hypertension, coronary artery disease, COPD, bronchial asthma, Parkinsonism, cerebrovascular disease, tuberculosis, but this is on the decline, anemia, and renal and liver disorders. This is the commonest comorbidities that we see associated with the geriatric patients. Across India, the anesthesiologists are well trained. There is a structured way in teaching them, educating them with skill and knowledge. And both government and non-government organizations are imparting knowledge and education in anesthesia in this country. And also, we are happy that we have two more systems, the physician assistants in anesthesia and also anesthesia technicians who help the anesthesiologists to make the perioperative care better. The resources that are available to do spinal anesthesia is quite widespread. This is done even in the smallest of small villages and in rural areas. And the equipment necessary for this is available throughout. Spinal is one of the most preferred anesthetic procedure for anything below that of the umbilical level. The next is general anesthesia. Workstations are available in all the medical colleges and the corporate hospitals, but we have a lot of indigenous anesthesia delivery system and machines which are produced in the country, which are used by several smaller hospitals. The only issue will be certain safety measures like oxygen alarm may be deficient in it, but otherwise the delivery of the anesthetic agent, oxygen and nitrous oxide is pretty assured. But in all the other big institutions, we have workstations, and the modern workstations have transformed the way we provide general anesthetic. However, when I say this, it's not available for every single anesthetist in this country. And from the inhalational, several centers in this country are moving towards target controlled infusion and total intravenous anesthesia. I think this is a game changer, and I look forward for the next decade belonging to TCI TIVA. And combined spinal epidural anesthesia is the other format that is used. Again, it's very prevalent in the big corporate hospitals, not so very common in the other hospitals which I've mentioned. But we have made a huge impact in regional anesthesia, both with landmark guidance, ultrasound guided, and peripheral nerve stimulator. The state-wise distribution, if you see, there are several states which have anesthesia machines present in almost every operating theater, and this resurgence has happened in the last decade. But in places where the ultrasound is not available, anesthesiologists use peripheral nerve stimulator and sometimes even the landmark technique. But I would like to admit, we have made an impressive growth in using regional anesthesia and site-specific analgesia in the perioperative period. However, much more needs to be done in this sector. And now I would wanted to tell a few of the ongoing research. We are very keen to collaborate on geriatric trauma, geriatric hip fractures, geriatric patients coming for joint replacements, because they have unique perioperative problems. And on arrival block for hip fractures, we have done several studies to show that how the outcome improves when they are made completely pain-free on arrival. This is one which I'm looking forward to collaborate with your esteemed institution. The other thing in my institution which we wanted to work through is the perioperative cognitive dysfunction of the elderly. And I think these two will form an important component of understanding and collaboration of research. Because we have such a huge population, it will be a great way to start. And also prevention of falls and osteoporosis. Being an orthopedic hospital, this is the second place where we can collaborate with your institution to make sure that we make a formidable progress in preventing osteoporosis and the fall. And the Neurosciences Institution, NIMANS in Bangalore, is doing a lot of work on dementia. And the Indian Academy of Geriatrics is involved in several studies, including the longitudinal aging study of India, which is quite a nice study. And now they've started the LASIDAD, that is the Harmonized Diagnostic Assessment of Dementia for Longitudinal Aging Study in India. Which is a population representative cohort study of cognition and dementia in elderly Indians. There's yet another research that's going on here. It's a North Indian study in adult outpatients of about 10,400, and it dwells with drug-related issues. It's very interesting, and I think this is another area to collaborate. Then there's another particular research going on in sinus node dysfunction, and they found statistically significant association of sinus node dysfunction in geriatric patients, especially in women. So at this point of time, I think a lot of work needs to be done in cognitive dysfunction, anesthesia for diabetic foot, preventive healthcare, example, osteoporosis, anemia, and diabetes. And I'm sure that we look forward for sharing more of our thoughts. But I'm very happy to say that when we had a anesthesiologist performing the role of perioperative physician, when there is a unified head with anesthesiologist taking the lead in the perioperative period, we have been able to share an outcome. And I'm very, very happy that we have done significant contributions in geriatric trauma. And I look forward for a day to welcome and invite you, some of you, to this country, and to make sure that you see and experience the development, progress, and growth of care for geriatric patient. It also calls for several more studies which will help us to create more research, audit, and result in an advocacy and a clear guideline and pathway with which the geriatric patients will be offered, which would be more procedure specific. Thank you so much for the opportunity, and I look forward to take this forward with all your help. Thank you so much.